Hi everyone, I'm Dr. Ye, currently an Associate Professor of Neurology in Taipei Medical University. This talk will introduce the management of stroke. This is my CV. These are photos taken when I visited to Kingdom of Eswatini in 2019. I enjoyed a great time and hope I can be there with you guys next year. Optimizing stroke management consists of identification, stroke type, onset time, diagnosis of ischemic or hemorrhagic stroke. For small vessel disease-related stroke, medical treatment with antiplatelet drugs. For large vessel disease-related stroke, intravenous thrombolysis with recombinant tissue plasminogen activator within 3 hours or intra-arterial thrombectomy are recommended in defined time window to save the penumbra and reduce ischemic damage. For hemorrhagic stroke, intensive monitoring of IICP and neurosurgical consultation are needed. All of the stroke requires aftercare, including risk factor modifications and rehabilitation to reduce the functional disability. Simply, we can divide stroke in two types, ischemic stroke and hemorrhagic stroke. Time is brain. We need prompt reaction to each stroke. The following questions can help taking history in 5 minutes or less. When less known to be well, what were the symptoms? Weakness, numbness, speech or vision problem? How quick did symptoms reach worse severity? Any change in symptoms since onset? Vitals from paramedics, including blood sugar. Medical conditions, including allergies. Medications, especially anticoagulants. If on anticoagulants, when last taken. And recent trauma, surgery, or stroke. This is a warning sign of stroke. Consists of B-E-F-A-S-T, be fast. B is for balance. Does the person have a sudden loss of balance? E is for eye. Has the person lost vision in one or both eyes? F is for face. Does the person's face look uneven? A is for arm. Is one arm hanging down? S is for speech. Is the person's speech slurred? Does the person have trouble speaking or seem confused? T is for time. Call the ambulance as soon as possible when you found the patient with stroke. The acute stroke evaluation includes a National Institute of Health stroke scale NIHSS. Because of time, please go to the video link for detailed description of NIHSS. It's by Johns Hopkins Medicine. This is the website shown here. The example workflow for acute stroke is shown here. For acute stroke, send to hospital with special stroke care facility as soon as possible. If the CT shows hemorrhage, then go to ICH management protocol. It includes the inpatient management ICU stroke unit with standard medical therapy. For ischemic stroke with symptoms onset less than 4.5 hours, check the eligibility for intravenous TPA therapy. If yes, give 0.9 mg per kilogram body weight dose. If large vessel occlusion such as ICA, NCA-N1, or basilar artery, subsequent intra-arterial thrombectomy is considered after scrutinizing the indication and the potential benefit. Those aim to save the penumbra and reduce the ischemic damage. The early ischemic stroke sign can be shown on CT, including hyperdense vessel sign, loss of the insular ribbon sign, lentiform blurring, loss of gray matter-white matter differentiation, and sulcal effacement. This is an example of progression of large hemispheric infarction. A large vessel occlusion can be seen on CT as a hyperdense artery and the effacements of sulci. It results in hemorrhagic conversion and a marked mass effect 1 day after the stroke onset. The NINDS TPA stroke trial, published on NEJM in 1995, showed an excellent outcome at 3 months, including the Barthel Index, Rankin Scale, Glasgow Outcome Score, and the NIHS score. All the scores are shown excellent in the treatment group. Within the defined time window, TPA can bring good clinical outcome in acute ischemic stroke patient. Infusion of analog of TPA, a thrombolytic drug, dissolve blood clot by activating a proteolytic enzyme plasminogen to plasmin. Fibrin molecules provide the structural scaffold for blood clots, and the plasmin cleaves cross-linkage between fibrin molecules. Subsequently, the clot becomes soluble and undergoes further degradation through proteolysis by other enzymes, eventually restoring blood flow. The dose we use for acute ischemic stroke is intravenous RTPA 0.9 mg per kilogram body weight, 10% IV bolus over 1 minute, the rest 90% IV infusion over 1 hour. This is a list of contraindications for intravenous thrombolysis therapy, including acute head trauma or severe head trauma within 3 months, extensive hypoattenuation of hemorrhage on head CT, ischemic stroke within 3 months, and the blood pressure, systolic blood pressure greater than 185 mm mercury, or diastolic blood pressure greater than 110 mm mercury, and cannot be lowered safely. Previous ICH and non-bleeding diastasis, suspect SH, and the INR greater than 1.7, intracerebral tumor and intracranial or intraspinal surgery within 3 months, and the platelet count less than 100,000 per millimeter cubic, active internal bleeding, and a GI malignancy or serious GI bleeding within 3 months, aortic dissection, and infected endocarditis. This is a case a 76-year-old male with right face, arm and leg weakness and numbness, plus aphasia and dysarthria. The last seen well is 2 hours ago. The onset is sudden. The NIHSS is 15. The past medical history including hypertension, dyslipidemia, type 2 DM, atrial fibrillation, and a smoker. The medication include candesartan, atorvastatin, metformin, and warfarin. The physical examination showed the blood pressure 195/110. The glucose is 90. The laboratory work showed INR 1.6. On the CT, you can see there's a hyperdense MCA artery. This case shows there's a small infarct core, but there's a large penumbra. This case subsequently received the IA thrombectomy. After the treatment, the recognition was demonstrated in the follow-up image and only small infarct left. The indication of mechanical thrombectomy for acute ischemic stroke including the following: time from time symptom onset, anterior circulation first 6 hours is recommended, can be up to 16 hours. Posterior circulation within 24 hours. The imaging CT, MRI, DWI aspect score greater than 6, and the smaller core infarct volume less than 50 to 70 milliliter, and the location of large vessel occlusion ICA and the N1, N2, NCA, and the stroke severity large vessel occlusion with NIHSS score greater than 6. Intra-artery thrombectomy techniques for acute ischemic stroke include catheter aspiration thrombectomy using suction to remove the blood clot, and mechanical thrombectomy. The blood clot is broken up into small pieces and removed. The criteria for endovascular therapy include pre-stroke MRA score 0 to 1. Some new score pushed is out of 2 to 3. Intravenous RTPA within 4.5 hours of onset is not a contraindication. Occlusion of the internal carotid artery or proximal NCA N1. Age greater than 18 years. NIHSS stroke score of greater than 5, and the aspect score greater than 5, and the growing puncture within 6 hours of symptom onset. This is a cartoon showing the procedure of the intra-arterial thrombectomy for acute ischemic stroke. This is another case, 69-year-old female with left arm and leg weakness and a decreased level of consciousness. Last seen well 20 minutes ago. Onset sudden. NIHSS 16. The past medical history include hypertension. The medication is amlodipine. The cause is worsening level of consciousness. The physical examination shows the blood pressure 178/76 at right arm, but 85/50 at left arm. The heart rate is 120. There's a AR murmur and a decreased breathing sound. The laboratory work showed anemia. In this case, the image of the chest CT can show seeing a dissection of aorta. The Stanford classification of aortic dissection distinguished two types. Type A, more frequent and severe, involves the ascending aorta and requires emergency surgery, whereas Type B affects the descending aorta. Type A can also affect the carotid artery and result in obstruction of blood flow. In case of 18 to 30% of patients with aortic dissection, neurological signs are first presentation, and among them, ischemic stroke is the most common. This is a case with headache, dysarthria, right arm and leg weakness. The last seen well is 30 minutes ago. Onset is sudden. NIHSS is 6. The past medical history is hypertension. The cause is worsening level of consciousness. The physical examination shows the blood pressure 220/90, glucose 140. The INR is 0.29, APTT 34 seconds. The CT can show seeing a hematoma over the basal ganglia, mainly involve the thalamus, and there's some intraventricular hemorrhage. The most common location of hypertensive hemorrhage is putamen, account for 35% of cases, followed by thalamus 20%, then pons and cerebellum. ICH, although less common than ischemic stroke, is the major cause of stroke mortality, and there is not yet a definitive therapy beyond supportive care. Early stabilization of acute ICH involves identifying and treating the causes of decreased alertness, aggressively correct blood pressure, and reversing any coagulopathy. Long-term management of ICH requires correctly identifying the underlying etiology and, when possible, correcting it. Initial clinical trials of minimally invasive hemorrhage evacuation were promising, and ongoing trials are evaluating new evacuation techniques. This slide shows neuroimaging features of various mechanisms of intracerebral hemorrhage. A. Hypertensive hemorrhage tend to occur in the basal ganglia, pons, and the cerebellum. B. Cerebral amyloid angiopathy classically causes lobar hemorrhage in elderly patients. C. Coagulopathy-related hemorrhages are prone to early expansion. The fluid level seen in the MRI is thought to represent hematocrit separation and is typical of hemorrhage associated with coagulopathy. D. Intracerebral hemorrhages associated with septic emboli may involve any part of the brain and often have more associated edema than expected. E. Hemorrhagic brain tumor may also be associated with greater than expected surrounding edema. F. Acute medullary hemorrhage due to cavernous malformation in a patient with congenital cavernous malformation syndrome. The etiology of primary intracerebral hemorrhage include hypertensive vasculopathy and cerebral amyloid angiopathy. The treatment strategies consist of excluding secondary hemorrhage, control blood pressure and other risk factors, reduce or eliminate anticoagulants and/or antiplatelet therapies depending on risk or recurrence. The etiology for secondary intracerebral hemorrhage include arterial venous malformation, infectious endocarditis, cavernous malformation, and hemorrhagic tumor. The treatment strategy consists of identify and treat underlying mechanism, MR image with contrast and CT angiography. For most cases, conventional angiogram when vascular malformation suspected, transesophageal echocardiography when infective endocarditis suspected. This is acute ICH management algorithm consists of first, ABC, initial assessment and stabilization of airway patency, breathing, and circulation. Second, neuroimage. Once clinical stability is achieved, an urgent imaging study for rapid and accurate diagnosis should be performed. 3. Standardized neurological assessment to determine baseline severity. The National Institute of Health Stroke Scale, if the patient is awake or drowsy, or the Glasgow Coma Scale GCS, if the patient is obtunded or comatose, should be performed and clearly documented. Fourth, blood pressure measurement, reversal of coagulopathy. Fifth, evaluation of a need for early surgical intervention. Sixth, frequent neurological examination to detect early clinical deterioration and signs of increased intracranial pressure should be part of the routine initial management algorithm. There are some predictors for hematoma expansion, including time from ICH onset to CT. Hematoma expansion tends to occur early in the course of ICH, with the majority, 26% of significant hematoma growth happening between baseline and the 1-hour CT scan, compared with only 12% between 1 hour and the 20-hour CT scan. And the patients on warfarin and the spot size on CTA, those are the prediction of hematoma expansion. The risk factor for ICH include hypertension is the most important modifiable risk factor for ICH. Poor control of blood pressure value is also associated with increased risk of recurrent ICH. Cerebral amyloid angiopathy, CAA, accounts for up to 20% of all spontaneous ICH cases. CAA-related bleedings typically arise from cortical-subcortical brain regions and frequently affect elderly patients. Alcohol intake. This relationship appears to be dose-dependent. Smoking. Current smoking increases the risk of ICH. Cholesterol level and statin use. In contrast to ischemic stroke, hypercholesterolemia has a protective effect against the risk of ICH. The association between statin and ICH risk is still unclear. Diabetes. The meta-analysis, including almost 70,000 patients, provides evidence in favor of diabetes as a risk factor of ICH. Genetics. The gene most strongly associated with ICH is the apolipoprotein E, ApoE gene, and its epsilon 2 and epsilon 4 alleles. Ethnicity. ICH incidence is higher in Asian populations. Drug abuse. Illicit drug consumption such as cocaine and methamphetamine is an important risk factor for ICH, especially in young adults. The principle of acute stroke management consists of vital sign support, subtype identification, etiology diagnosis, prevention of deterioration including adequate hydration, ICP management with or without operation, anticoagulation therapy, heparin or low molecular heparin use, and thrombolytic therapy such as TPA or mechanical thrombectomy. Prevention of complications include aspiration pneumonia, pressure sore, urinary tract infection, dehydration, upper GI bleeding, stress ulcer, deep-vein thrombosis, neurogenic bladder, painful shoulders, and limb contracture. The early and advanced rehabilitation is important for stroke patients. Survey and correction of stroke risk factor. Second, prevention, including medication with or without surgery. The education for the lifestyle modification, fluid nutrition status, exercise, diet control, smoking, alcohol, and body weight reduction. The medication include antiplatelet, aspirin 100 mg, clopidogrel 75 mg, anticoagulant, oral warfarin, low molecular heparin, direct anticoagulant, surgery, endarterectomy or stent, bypass, angioplasty if symptomatic carotid stenosis patient, and the stroke. Some special treatment for stroke include the stroke involution. The definition is progressive deterioration of neurological deficit during the period of observation. For carotid is 24 hours after onset. For VP system is 72 hours after onset. The management consists of an emergency CT for rule out ICH or early large infarction, anticoagulation therapy with IV heparin or subcutaneous low molecular heparin, Dextran as a volume dispenser. The heparin used is acted with antithrombin 3. The initial bolus is 5,000 to 10,000 unit IV. Then continuous infusion with 1,000 units per hour, approximately 10 to 20 units per kilogram body weight per hour. And we need to check the APTT every 6 hours and keep APTT ratio 1.5 to 2-fold. For the therapy of DVT, we use the heparin 10,000 to 20,000 units a day. The low molecular heparin, such as enoxaparin, fenfluramine, act with factor 10A. The use is 1 ampoule subcutaneous every 12 hours. It's convenient, safe, and less side effect. The indication for heparinization or use of low molecular heparin include basic artery occlusion, frequent TIA 3 times in recent 2 days, shock involution, embolic shock, and other conditions such as cerebral venous thrombosis, pulmonary embolism, deep vein thrombosis, atrial fibrillation, and ANI. The ICP management is important in acute stroke care. The symptoms consist of headache, projectile vomiting, puppy edema, and Cushing triad. The management consists of head elevation 30°, osmotic agent, mannitol 150 ml state, then 75 ml every 4 hours to every 6 hours IV infusion, or glycerol 250 ml every 4 hours to every 6 hours IV infusion. Furosemide dexamethasone for vasogenic edema. Hyperventilation can reduce the blood pressure, keep the PaCO2 25 to 30 mm mercury. Decompressive craniotomy if needed, and barbiturated coma therapy. Another important issue is hypertension therapy. Hypertension results in poor outcome, especially when consciousness impairment. Chronic hypertension can show the right shift of blood pressure per cerebral blood flow curve. The brain hypoxia when the mean blood pressure less than 70 mm mercury. The general principle of BP control: not too low, not too fast. For the ischemic infarction, the systolic blood pressure less than 220 or diastolic blood pressure less than 120. For the hemorrhagic infarction, the systolic blood pressure less than 180 or diastolic blood pressure less than 100. The drug choice for hypertensive control according to other medical problems. The risk factor of ischemic stroke include major risk factor: all age greater than 65 years old, hypertension, diabetes, heart disease, and previous stroke. The minor risk factors: smoking, alcohol, hyperlipidemia, polycythemia, obesity, immobility, family history, drugs, and recent infection. The those with red are modifiable. The prevention of stroke include primary prevention consists of hypertension treatment, anticoagulation for atrial fibrillation, and lifestyle modification, starting for dyslipidemia and influenza vaccination. The secondary prevention for ischemic stroke, the blood pressure and cholesterol are important, and the anticoagulation for atrial fibrillation, lifestyle modification, antiplatelet therapy, carotid endarterectomy or stenting for symptomatic carotid stenosis. The hemorrhagic stroke, the most important is blood pressure lowering. The goal for stroke prevention for blood pressure is less than 140 over 90 mm mercury. In patients with diabetes mellitus, the blood pressure should be less than 130 over 80 mm mercury. For diabetes sugar control, the HbA1c less than 7%. For dyslipidemia control, the LDL should be less than 100 mg per deciliter or reduction 50%. And for lifestyle modification, quit smoking, quit alcohol, healthy diet, adequate hydration, good sleep, and regular exercise. The secondary prevention include the antiplatelet drug, aspirin, or clopidogrel, anticoagulants for cardiogenic emboli or non-valvular atrial fibrillation. We can use warfarin and direct oral anticoagulants such as dabigatran, rivaroxaban, apixaban, and endosaban, and carotid endarterectomy or stenting for symptomatic carotid stenosis. Several range of motion exercise in stroke patients can be started as early as possible to prevent the limb contracture, including the shoulder elevation, shoulder abduction, finger flexion extension, and the knee flexion and the foot dorsiflexion. I use this picture from internet to summarize the rehabilitation and aftercare of stroke. It's including general rehabilitation principles, upper limb function restoration, gait balance and mobility training, cognitive training, emotional well-being and mood change, visual and speech issues, nutrition and swallowing training, pressure sore prevention, infection control, and the venous thromboembolism prevention. The goal is to reduce the disability and return to normal life. The summary: the optimizing stroke management need a team care from identification, diagnosis, acute management, prevention, strategy, and aftercare. This effort will make stroke better. Optimizing stroke management requires a team care. This is our TNH stroke team. We have received Symbol of National Quality Award in 2020. Our aim is to make stroke less and make stroke better. Thank you for your listening.